Yes, thank you very much, Raquel. So now you have seen the context of the three buyers, also the challenge, why advanced heart failure, and also Raquel explained the TIQUE model and the scope. But since this can be still a bit abstract, we are going to put it down in some use cases. So we'll have three different use cases explained by three different doctors in San Pau Hospital. And these three use cases will illustrate three different stages of the advanced heart failure or the related pathology. So first of all, we'll have the initial heart failure use case. And to explain it, we'll have Dr. Sonia Mirabet, which is the chief of the heart failure unit at San Pau Hospital. Please, Sonia.
Good morning, everyone. This first case is a patient. Manel is a 68-year-old man from Barcelona. He lives in an apartment with his wife, Irene, and they have a daughter that lives in a city close to Barcelona. Manel has hypertension, diabetes, and obstructive sleep apnea syndrome, and he was admitted for heart failure 5 years ago, and then a non-ischemic myocardiopathy with severe systolic dysfunction was diagnosed. Medical treatment, according to clinical guidelines, was started. He used to go skiing with his family, play golf with his friends, and go for long walks with his wife. However, he stopped skiing after the heart disease was diagnosed. In the next few years, Manel has experienced more difficulties walking long distances and shortness of breath when playing golf, so he has stopped exercising. He feels that he has poor quality of life. He's currently taking 6 pills every day. In the past 6 months, he has been admitted to the emergency department at the hospital 2 times for heart failure. At the first admission, atrial fibrillation was detected. Manel was treated at the hospital, and after the symptoms were controlled, he was discharged and sent back home with a new treatment. In the next days, he did not feel good. He's playing short of breath, walking short distances, so he has been at home most of the time and got depressed. 3 months later, Manel feels pain on his knee and takes ibuprofen. After a few days, he was admitted again to the emergency department with increased dyspnea and decompensated heart failure. What will happen in TIQUE's model? In TIQUE's model, after the first admission to the emergency department, Manel is identified as a patient of the San Pau Hospital Heart Failure Unit and included in the TIQUE's Virtual Care Center. Medical treatment and education is carried out at the Heart Failure Unit to prevent readmissions, to improve survival, but to increase his quality of life. A case manager is assigned to Manel, and the case manager is the person of contact for him. The case manager supervises his health status and contacts the care team that will attend Manel when necessary. The case manager coordinates Manel's attention between hospital and primary care and gives information to Manel about his condition and how to manage it properly. Gives information about the potential drug interactions and side effects, and gives information about when to consult with the care team. Also, a device for the remote monitoring at home is included in this TIQUE model, and the device tracks his health parameters and integrates data in the virtual care center, where information is processed and alerts are activated 24 hours a day and 7 days a week, allowing proactive actuation of the care team to prevent further discompensations. Manel reports feeling increasingly tired and having difficulty for performing daily tasks as shopping or cooking. Manel's tracking device shows that he's not breathing properly, and the clinical team and the virtual care center receives the alarms. The case manager visits Manel at home, activates the emergency services at home, and intervenes furosemide is administered at home, improving her health status. The case manager reports this unusual event and informs the cardiologist and the GPs. The case manager schedules a visit with her unit during the next days for follow-up and control, and also updates managed medical records and discusses the next step with the medical team assigned to him. Also, social support is activated to help Manel with daily tasks. Psychological support is also activated, and a rehabilitation program with daily task supervisor. Thank you.
Thank you, Mireia. And now to explain the next use case, we'll have Dr. Marta Antonio, which is a cardiologist at the heart failure unit at St. Paul Hospital. Please, Marta.
Thank you very much. Hello to everyone. So we're going to talk about Montserrat, which is a 75-year-old lady who also lives in Barcelona. She's suffered from heart failure for the past 10 years and has other diseases such as renal disease and has a pacemaker. She's living at home at her own, but has two siblings who visit her every day. Over the last years, she's been showing that her heart problem has worsened, and she gets very short of breath on minimal exertion. She's getting very, very weak and needs a walker to move around. So she's limited to activities such as walking or going shopping and needs increasingly more help. So she's taking 11 medications 4 times a day, and her condition is worsening. She gets short of breath with swollen legs, and it has had these compensations many times over the past year, and she's been admitted to the emergency department on 3 occasions. So she is not able to detect when she's decompensated. So after all these decompensations, and because she can't look after herself properly, and she needs 24-hour support, she gets moved to a nursing home. This nursing home is medically equipped, but doesn't have physiotherapy or the emotional support that Montserrat needs. Montserrat stated her end-of-life will, which would be to be at home and die at home if it's the case, and she stated that she doesn't want to die at the hospital. Even though she expressed that, every time she gets the compensation, the emergency department take her to the emergency department, and where she finally dies. So in a TIQUE enhanced health system, knowing that she's in a very advanced condition of her heart failure and that she's not a candidate for more advanced treatments such as heart transplant or left ventricular assist devices, after one of these admissions to hospital, a case manager would be assigned to her case. This case manager would establish a direct connection between all the carers. This would be the primary care, the hospital doctors, and the social services. And all the information about Montserrat would be registered in this virtual care center, which would show medical records of her visits to the hospital or any change in medications. This care manager would also show Montserrat or give all the education on how to detect these decompensations of heart failure and how to act with any of the decompensation to try to treat these compensations as soon as possible. The case managers also, all the teams, she would have at home monitoring devices to monitor her vitals, movements, activity, food intake, and all this information would be integrated as well in the VCC. And a 24/7 support care team controls of Montserrat Health through all these devices. So when the system predicts an imminent decompensation, so different alarms would be activated, and the care team would activate a home visit for Montserrat, and it would also get an alarm for the hospital team that would be ready to give support if she needed to be transferred to hospital. So in this case scenario, Montserrat is visited at home. Her decompensation can be managed at home and she doesn't need to be transferred to hospital. She also, as the social services have been contacted as well, she gets social support at home for shopping, hygiene, and she doesn't need to be transferred to a nursing home as she prefers to stay at home. The other important issue is that the end-of-life will of Montserrat is very free and available for everyone in this virtual care center. So she details that she doesn't want to die at home. And also when the time of death approaches, a palliative care team is activated and can be treated at home and to treat not only cardiac symptoms, but also pain, anxiety. So when she suffers another decompensation, she's not transferred to hospital and she can die at home peacefully. Thank you very much.
Thank you, Marta. And finally, to show a use case regarding advanced heart failure and frailty, we'll have again Dr. Mireia Puig from our emergency department. Thank you.
So Joanna is a 92-year-old woman who lives in Barcelona. She lives in an apartment with her 88-year-old sister Pilar. Joanna was diagnosed with heart failure 8 years ago and suffers from multiple comorbidities such as type 2 diabetes, chronic renal failure, and mild dementia. In recent years, Joanna's mobility has decreased. She needs a walker and hardly ever leaves her house. Due to her heart disease, she suffers from dyspnea related to small exertions and becomes fatigued with simple tasks such as daily hygiene. Her sister Pilar takes care of all the housework and also takes care of Joanna. Pilar is also very old and taking care of Joanna is a great effort. Joanna is taking 11 pills every day. In the past 3 months, she had been admitted to the emergency department at the hospital twice. On one occasion, Joanna had a urine infection that Pilar did not notice until she had high fever, significant disorientation and dyspnea at rest. On another occasion, Pilar observed how Joanna progressively had edema in her legs, but she could not take her to the primary care center until she had dyspnea at rest and had to call to the emergency services. Pilar feels that it's becoming more and more difficult for her to attend to Joanna. She lives with the fear that Joanna will suffer a decompensation. The admission to the emergency department makes Joanna return home weakened and more disoriented every time. Now, Joanna has been sleeping worse for a week, droning in bed, and the 2 previous nights she had to sleep sitting on the sofa. She's more disoriented, she does not want to eat and drinks very little. Pilar has administered her usual medication. But today at noon, Pilar found Joanna with dyspnea at rest, very sleepy, and she did almost not respond. Pilar called to the emergency services. At the emergency department, she was diagnosed with an exacerbation of her heart failure, worsening of her kidney failure, and severe dehydration. She had to be admitted to the hospital. In TIQUE's model, after the first admission to the emergency department, Joanna is identified as a frail patient with complex needs. It's also identified the need of support for Pilar. The multidisciplinary team of the emergency department evaluate the situation of both. Doctors and nurses make the diagnosis and plan discharge care. The pharmacist reviews Joanna's medication, eliminates some drugs, and explains the new medication to Pilar. Anna, the social worker, contacts the primary care team and requests subsequent follow-up at home. Joanna's treatment is adjusted. Raquel, the ED geriatric nurses, updates the protocols through TIQUE's virtual care centers. And these are received with the monitoring center and the pharmacist, and also updated Joanna's clinical records. Raquel also gives Pilar information about Joanna's conditions and how to manage it properly, about the potential drug interactions and side effects, and when to consult with the care team. Joanna is also given a very simple device for remote monitoring of her vitals and movements. This device will constantly track her health parameters and integrate the data in the VCC, where information is processed and alerts are activated for 24 hours for 7 days a week. allowing proactive actuation of the care team to prevent further decompensations. After being discharged from the hospital, she receives regular visits from the nurse at her primary care center, during which Pilar can ask questions and comment on her doubts. They have some home support from the City Hall, who provides them with a person to take care of a housework twice a week, helps with Joanna hygiene, and makes it easier for Pilar to go out of the house for a walk. Pilar is also calmer since she knows that Joanna is monitored and that the VCC will detect any worsening of her condition before she noted it. 1 month after discharge, the clinical team at the VCC receives an alarm from Joanna's tracking device, showing that her movements have slowed down, that she's sleeping less, and has gained 2 kilograms in a week. The clinical teams activates at-home hospitalization. They treat her with intravenous furosemide, thus preventing Joanna's admission to the hospital. They also adjust the medication to avoid drug adverse effects under the new situation. In 2 days, and without needing to go to the emergency department, Joanna has returned to her usual situation because early detection avoided the cascade of alterations. After 2 days, Joanna was discharged from hospital at home. During the following week, the VCC contacted her to adjust the medication and ensure her stability, and Joanna returned to her baseline monitoring situation. So in the slide, you can see the main problems resumed and how TIQUE services allows treatment control adherence, education, empowerment, and autonomy for patients and their careers, the tracking device for VCC control, monitoring control, and case manager for integration among care teams and VCC control. Thank you very much.